So, it is really a pleasure and privilege to be here tonight. Thank you very much for the invitation to take part in this very exciting evening, and looking forward to it, as well as to the questions and answers session coming after this lecture. My name is Ron. I'm a public health physician by training, with also training in epidemiology, statistics, and management. And in the last decade, I've been working for Clalit, which is the largest healthcare provider, payer provider system in Israel, that we'll talk a little bit about. Now, I will try to speak approximately for about 45 minutes. This is by no means prepared to be a lecture. I would really, if there's something that's in the middle that you feel that strongly that you want to ask, please do so. Otherwise, if I'm accidentally saying something interesting, stop me. Otherwise, I'll understand. And I think with no further ado, I'll just jump forward. And we're starting with some facts that are very clear to those of you in the room who are physicians or nurses or allied health professionals. When we go to work every morning, we are acutely aware of the fact that we're working in a failing system. We are aware of the fact that by some assessment, nearly 30% of the care that we provide is no value added or damaging. And these are figures that have become more and more validated in different healthcare systems. We are aware of the fact that we're missing many of the opportunities to provide the evidence-based helpful practices that we should be providing. And that by some assessments, although contested, it is the case that healthcare provision and honest mistakes made by wonderful, dedicated healthcare professionals trying to do their best are the #3 cause of death in most Western countries. And the problem is that they're working in a system that does not account to the fact that they're human. And humans make mistakes. And it is the responsibility of the system to prevent these mistakes from becoming a fatality. And we are failing them day in and day out by creating health systems that are not taking this into heed. So with this reality, and with resources becoming more and more limited, and demand continuously increasing, this seems to be a problem. Now, imagine it could be different. Imagine that you could look into the future, and you could see that something bad is going to happen to someone, and that you have the ability, the capacity to do something about it, to take him out of harm's way and show him a way to avert these outcomes. What would healthcare look like in such a scenario? Maybe it would look like that. Instead of going to your physician, calling them with your ailments and your requests, one morning, your healthcare provider, she will call you and say, "Good morning." "Good morning," you'll reply. "How are you doing this morning?" "Fine," you'll reply. "Oh, that's great. Because, you know, our data suggests that you will have a heart attack in 6 hours. So why don't you come over to the office so we can fix you and prevent that?" Sounds like science fiction? It's not. This type of healthcare is being provided in different health settings around the world these very days. And actually in the country and in the health system that I come from, it is happening in massive scales every day. Let me give you one example. Some of you have friends or family with chronic renal failure, and you know how debilitating and painful this condition is for the patient, for the family, and how wonderful it would be if you could do something to avert that from them. Well, in order to do that, it's not good enough to come when the patient is already symptomatic. By then, the damage to the kidneys is unchangeable. The pathological damage is entrenched. If you want to make a difference, a true, meaningful difference, you have to come very early, when the patient is still asymptomatic. But that's a problem, because everybody in this room are asymptomatic. How would you know who to tackle? None of our health systems have the resource to just address everyone. How do you choose? Well, nowadays, we have the capacity to look into the future, to be able to use the power of predictive power, of new algorithms, of AI, of various predictive mechanisms in order to be able to predict this future. Now, if you'll think about that for a second, this is not a small change. This is a paradigm shift. We're trying to move from what we have today in our healthcare system everywhere. We have a reactive therapeutic paradigm. If you have pain, you come in. If you feel well, you stay away. When it actually should be very different. It should be based on population health, about predictive, proactive, and preventive. And this is a huge difference. The only way to tackle the resources, the challenge of lacking resources in a health system that needs to provide more and more care to a population that becomes older and more multimorbid, you have to divert from the upper side to the lower side. Otherwise, it will never be sustainable. And so, how can we say who will have 5 years from now chronic renal failure? How do we know who those patients are? Well, we need a lot of data. In order to understand how we get such data, I have to give you some background about the health system I'm coming from and how this came to be possible. So Israel has a population of about 8.5 million people with mandatory enrollment in the health system for all. So it's universal coverage from birth. All the care is being provided by 4 national organizations that are termed sick funds. They are payer-provider systems. They are both the payers and the providers, and they're all non-for-profits. So these 4 systems, these 4 sick funds are responsible for your care, basically from cradle to grave, unless you choose to move. And it is really easy to move from one to the other. If you are enlisted in one and if you want to move to the other, all you have to do is go online, click a button, and you're there. So you'd imagine many move, right? We'll talk about that in a second. There's very low co-payment. So if you go to primary care office, you don't need to pay. If you go for emergency inpatient care, you don't need to pay. If you have to take the appropriate care, very small co-payment. So this is very equitable. And basically, and I think this is really key to understand, our core values are very much in sync of that of the UK healthcare system. Our core values, as they are mentioned in our law, in our national insurance law from 1995, is that the Israeli healthcare system shall be based on the principles of justice, equity, and solidarity. And so not that many healthcare systems around the world hold these as their basic foundation, and everything I've shown you is built in order to provide for these core values. Now, the competition between those 4 organizations that I told you about is not on cost because you don't pay us, you pay the government. It's not on the list of services because that's also determined by the government. So what are we competing on? On quality and on service. And we can't spend too much on marketing because that's capped by the government. And you can easily move from one to the other, as I said. So what do you expect the movement to be? Dramatic. But in practice, less than 1% move on every year. And largely speaking, 90% of Clalit patients born at Clalit will, at the age of 82, die as a Clalit member. And we've been there for over 108 years. So there's a few that went through the entire cycle by now. And why? That's because we have some serious surveys that say that 90% of the people are either happy or very happy with the care they get from the sick funds. And these are Israelis. They're happy about nothing. Okay, so this is really, really surprising. And so we're doing something well. Let's talk about funding. This is the health expenditure per PPP in dollars. And this is a comparison of Israel, the UK, and the United States. I don't think it takes a lot of explanation about what these figures mean. The system, in terms of incoming funds, is starved to the maximum. So we're trying to do a lot with very little. But you would expect such low investment. And you know, we are in 7.3% of GDP for over 15 years now, straight. No change, no escalation. And so what would you expect in terms of outcomes? You'd expect lower outcomes. But, you know, for men, life expectancy in Israel is number 3 in the world, basically. So again, something seems to be working well, and we'll try to kind of decipher today some of the core things that make this possible. So Clalit is the largest one of those 4 organizations I was talking about. It holds 53% of market share over, by now, now by almost 4.4 million people, and mainly the 6 segments of society. And it's all under one roof. It's all integrated. 1,500 clinics. The joke in Israel is you throw a stone everywhere you are, you will hit the Clalit clinic. Doesn't matter where you are. Every desolated, you know, place around the country, that's always there. 30% of the Israeli acute beds belong to Clalit, and we're a national leader in telecare, in digital health. In one of the videos that you've seen before, there was a demonstration of the small thing called Title Care, which is a local Israeli innovation that allows our physicians to be listening to the heartbeats and to be looking at the throats and the ears of every patient at home. So we can do the physical checkup from afar. And this is by now available everywhere, and you can call this, and it's for the telecare service for Clalit is free. So you call out of hours, and you can get free access. So because we are payer and provider, and because we are longitudinal, we have all the data in the world, and all this data is accumulated into one data warehouse where it is available for stuff to be done with that. So think about it, 4.5 million patients with 20 years of longitudinal data, cross-linked EMR and claims in one place. What would you do with that? Exactly what I've shown you before. You'll be able to do things like, for the first time, be able to tell which of the 3 largely available predictive models for osteoporotic fractures works best. So these were developed in different parts of the world, and nobody's been able to put them under one equating system to show which one works better. But because we have this longitudinal data, we've been able to do it for the first time and show which one works better for the others. And maybe create something that is even better than all of these 3 altogether. We'll talk about it in a second. So in order to be able to do this, you need people who know how to use real-world data and to use it in a smart way. And we have created the Clalit Research Institute, which is a group of about 50 scientists, epidemiologists, mathematicians, AI specialists, data scientists, clinicians, all working together in ad hoc groups, trying to reinvent healthcare and to create new tools and then put it directly into practice at Clalit and learn from the outcomes how to keep on improving. And that seems to be working pretty well. But you know that when you do these types of algorithm development, in many cases, they are, in practice, black boxes. Now, do you think physicians like black boxes? Do they trust black boxes? Would you? So what I would try to do now is just to give you a glimpse into one of our studies to understand what this black box means. So the examples is actually from a study we done a few years ago about osteoporotic fractures. And we wanted to predict which patients will break their bones and due to osteoporotic fracture, which is when the bones become more amenable to fractures. And so our data and our algorithms suggested that there is a very strong association between eye disease and the osteoporotic fracture. And I said, well, you know, I graduated med school. There's nothing association between eye disease and bone disease. I'm sorry, there's no such thing. This is a glitch, right? Anybody here with medical background? There's no such association. So we ran the models, and it persisted again and again. And then eventually it hit us. It's really simple. People who have eye disease don't see well. When they don't see well, they fall. And when they fall, they break. So this is what the computer was able to understand from our data that we could not. And so many of those things that lie within those black boxes have internal inferences that computers can identify, and we may not be able to until we were explained. And it's sometimes difficult for a physician to make this assessment in real time. So what I will do today is I will show you a few examples of how we are trying to transform care through data to this predictive, proactive, preventive, integrated approach as compared to the status quo. So we started talking about proactive care and preventing deterioration. We'll talk a little bit about improving test interpretation accuracy, but very little, because the rest, soon afterwards, I will not scoop Eyal's talk. We'll talk a little bit about divesting in futile interventions and policies. As I said, 30% of what we do is futile. It's good to know which 30% it is. And I'll maybe briefly discuss a little bit about precision, about safeguards from error, and about patient self-care, all depending on time. Okay, so we've talked a little bit about proactive care, and now it's time to move onwards from that point, and what we'll do now is talk about test interpretation accuracy. So, what do you think is the future of this profession? First of all, the good news is there's not enough specialist surgeons. So, you know, any new surgeon that will come into this business of radiology will have work almost immediately, because there's not enough. Many of these scans are not being even read. But nowadays, when we know that machines can actually decipher images better than humans, how long would it take before we automate some of these processes? So, fortunately, and this is the last slide that I will show today, we have a collaboration with Zebra Medical Vision that we'll talk later on, that have started with the Clalit data sets, with its richness and all of the automated and digital data on radiology, and nowadays is growing by the day in an exponential way. We've been able to create, for instance, algorithms that can look in this CT, can look at this bone, this vertebra, and say that there seems to be osteoporosis lying there. Now, the eyes of the radiologist cannot do that, but the machine can. And with recent results that were unveiled 2 months ago at the RSNA, we've actually shown that this can be better than the existing available modalities to assess this vulnerability. But you'll hear more from Eyal about that. So this is an example of how we can take the richness of what the startup nation can bring and bring it into practice. And right now, we are those algorithms are being put into massive scale of implementation in Clalit, and hopefully soon in other organizations as well, in Israel and outside. So you've heard before, Israel is pretty unique in terms of the innovation ecosystem. It is like a boiling plate. Every person who has not opened a startup is a failure to his mother. Yeah, you're only a physician. When will you grow up and start your own startup? So maybe I'm exaggerating a little bit, but there's a message there. There's a very strong drive for people to come and make it on their own. And even within this specific area of digital health, there are over 600 companies, over 1,700 companies in health and biology in general. And there's hundreds coming in every year. So this is a boiling pot of ideas and excellent. And if we work with them in co-designing the solutions to be meaningful for the healthcare, the everyday practice, this can actually transform the system. And we'll show some examples. So, which brings us to the biggest challenge. So there's a lot of things happening around the world, which is really beautiful in the lab. But the question is, how do you bring it into the clinics? How do you bring it to the patient's hands? So I've shown you something about how we take the predictive models and put it on the screen of every physician so they can tell their patients that they are at risk and tell them what to do in advance in order to prevent the damage for the kidneys. Or we come to pre-diabetic patients of those at the highest risk and prevent them from becoming diabetic. We come to the patient and we allocate our flu vaccines every winter, ranked by the risk of that specific patient having pneumonia on that winter. We have the same for malignant diseases and for chronic diseases and for infectious diseases. Really interesting and growing all the time. We now have an ongoing work on preventing stroke by identifying patients at high risk. But the key thing is how do you take it and maybe you skip the physician in the loop. And you know, there's a serious problem about the willingness of patients to actually take the recommendations of their physicians seriously. And sometimes it's really tough to get through, and maybe some of those predictions can help us do that. For this purpose, we created what we called Ideal Health, which is our newest app that has, I would like to show you really quick preview into it. And let's see how that works.
When patients receive a warning from their doctor about their medical risks and how to prevent them, they can be so overwhelmed with all the difficult changes they need to make, they usually just give up on even trying. Ideal Health, our AI-based, data-driven app, helps individuals focus their efforts and supports them and their care providers into taking action. Using individualized medical data from the electronic medical records, one can visualize a personalized risk for multiple diseases and potential improvements by visualizing the effects of modifying risk factors. As opposed to other online calculators, our advanced causal inference algorithms help to demonstrate how the risk changes if the individual accomplishes different goals. With Ideal Health, individuals perceive that the risk is real and are empowered to best choose which goal to pursue according to their preferences. The patient's provider receives notification of their selected goal, as well as action items to approve, like a prescription for medication, referral to lab tests or support groups, and follow-up visits. The referrals are automatically sent to the pharmacy, test labs, or support group, and notifications are included on the patient's calendar. Ideal Health helps the patient to better understand their medical situation and how to take action to improve it. All with the support of their medical data, medical provider, and medical team.
So this is not a concept. This went live 2 months ago on a quiet launch. And we are now testing the ground. We actually embedded in this app that is now available to every Clalit member through their online usual app. We actually also embedded there a randomization mechanism. So in due time, we can actually see what was the impact in a proper way. Because in many instances, it is impossible to tell what you've actually done after you've done it. So this is really important. Also worthwhile saying that we've submitted this to the Google and AMA Interoperability challenge, and now we have a lot of Google Cloud points. We're trying to figure out what to do with, but so this was interesting. So I think that we've seen how we can help patient self-care, and there are several examples. This was just one. Let's now maybe move to something else and talk a little bit about divesting, because it's always easy to say how to do more and how to spend more, but maybe doing less could be an interesting strategy. So in order to know what to do less, you need to know what actually works. Now, how many of you think we actually provide to our patients evidence-based medicine? Okay, see, many of you, you actually, okay, that's a good starting point. The problem is that there are several challenges with dogma. First of all, in many cases, the ability of us to treat our patients based on randomized controlled trials is hindered by the fact that those trials are not really relevant to the population that we're actually seeing, because many of those trials were not based on population with multimorbidity, older women, and other neglected populations. But not only that, in many cases, it is really difficult to infer from the data, from the paper to the patient sitting in front of you. And so we really want to know what actually works. So at some point, I will give you 3 brief examples just to understand how this works when you have all the data and you have the epidemiological teams to analyze it in real time in order to understand what works and what does not. So we have understood that we have a record number of bariatric surgery, that's weight loss surgery, being done in Israel. That doesn't make sense. I mean, land of milk and honey and everything, but no. That doesn't make sense that we should be the highest percentage proportion of performing these surgeries. And so we started asking, are we actually doing too much there? Maybe we're just, too enthusiastic with our hands on the scalpels. So what we did was to do a study. And we started looking at, and unfortunately, we have over a decade, tens of thousands of patients under surveillance, if you'd like, retrospectively. And we've actually tried to see what was the impact. And the impact was pretty clear cut. We were halving, by half, the rates, mortality adjusted rates for these patients undergoing this surgery. We were actually doing a huge favor to those patients that underwent this surgery. It did the trick. So the selection process was pretty decent, and the outcomes were very good. And in the same JAMA issue that this was published, there were 2 clinical trials that have shown similar results. So they had 300 patients approximately each one, and we've had 30,000. So it's, there are a lot of drawbacks in using retrospective and real-world data, but there's some strong points in trying to use it to make decisions. Here's another example. We provide to the elderly the pneumonia vaccine, the polysaccharide 23-valent vaccination against pneumococcus, which causes pneumonia. Is that a good idea? We provide them to everyone, every elderly. Does it work? You have to know. I mean, there's decision makers in this group which are actually making this a policy. And in this country, you are giving this vaccine to these patients. Does it work? That's not a good position to be in. And we have many, many decision-making processes based on such facts. So again, what we did was look at the data. And we were able to look at the data which others cannot because we have all of this abundance of data. And what I will tell you the outcomes. When it comes to pneumonia, hospital-treated pneumonia, which you can see here in the bottom, the odds ratio for those getting the vaccines, those not getting the vaccines, was 1.00, with very small margin around 1, which means this vaccine is good for this purpose as well as distilled water. Only it's not as sterile. So we should stop giving this vaccine, right? No, because we tested another outcome, which was the invasive pneumococcal disease. Those, when the bacteria goes to the bloodstream and actually causes serious harms. And the vaccine efficacy for that was 0.6, which means we prevent 40% of these fatal complications. So instead of saying this is the vaccine against pneumonia, which it is not, it's the vaccine that prevents the pneumonia from killing you, which is very different. You'll have the same number of pneumonias, but you will not die as often because your bloodstream is protected. So this is really interesting. This allowed us to say we have to increase the number of vaccinations that are provided in our system, which we did. And the outcomes came just after that, with a drop in the amount of invasive pneumococcal disease, which is a deadly condition. So this is really cool. The last example I'll give is on the case of antibiotics. We all know that you should have antibiotic stewardship, and we shouldn't give wide-spectrum antibiotics to everybody because that's detrimental for the, that creates bacterial resistance, which is not good for us as a society. So we went to our data, and we found something really interesting. The areas in which we had the highest provision of wide-spectrum antibiotics were the areas where we had the largest amount of resistance of the bacteria to the same antibiotics, which means as a physician in those areas, as you provide this more expensive, more wide-range antibiotic, you give the patient the wrong drug, which is not effective to treat their bacteria. So you're doing the wrong thing in so many ways, for the patient, for the community, and for the health system. So showing this data helps. There's some even more interesting data coming in, but it's still under embargo, and within a week it will become published in one of the major journals out there. So I think these are some pretty interesting examples, but we haven't yet touched the most pressing issue, which is treatment. And treatment is a balancing act. Too much, let's say, of anticoagulants or hypertensive treatment is dangerous. Too little is risky. the exact point of equilibrium, the exact point of optimum is personal. It changes from person to person. But the data that we have to base our decisions as physicians comes from the papers, and the papers have averages of telling what is better for one population versus the other. So we have average data to make a decision about every person. But none of us is average. And we don't want to get treated based on average outcomes. We want to know what's best for us. And how can we do that? Well, it's a question. You know, one of the most famous physicians of all time, Sir William Osler, he said this sentence that I think is key. He said, if it were not for the great variability among individuals, medicine might as well be a science and not an art. Medicine might be a science and not an art. Isn't it great that medicine is an art and not a science? How many of you want to be treated by artists? So we have a little problem here that we need to take care of, and maybe we can make medicine a little bit more of a science and a little bit less of an art, while maintaining the humane part of it. And let's see how it can be done. So if I see a patient in front of me, I can base my knowledge on the number of patients similar to him that I've seen in the last 20 years of practicing, or 2 years of practicing if I'm new to this. Or I can base my decision on the collective wisdom of many patients that were treated in my health system that's available in my data, and ask what worked well for them, and then provide the same treatment to this patient in front of me. That would be cool, wouldn't it? So we test drived it on data from the New England Journal of Medicine Sprint trial that was done in order to show whether intensive treatment of hypertension is good or not for a certain subgroup of patients. And it has shown that it is better to give the intensive treatment to that subgroup. So we looked at the data, and indeed, on average, it's better to provide the treatment. There's more benefits than harms on average. But when we did individual modeling to every single patient, it turns out that there's a very large, almost half of the patients, but less than half, that would be hurt by this intensive treatment. And you can tease them out from the rest of the population that would benefit. So instead of giving an average treatment effect, you can start talking about individual treatment effects. And so we did this with data from the New England in what they call the Sprint Data Analysis Challenge, where they challenged all of the best and biggest machine learning, epidemiology groups around the world and told them, here's the data, good luck. So we said, why not? We could compete. Everybody was there, Stanford, Harvard, Broad Institute, pharma companies. So we said we might just try. And what we did this individual modeling exercise where for every patient we saw what is for him, thousands of models run for each one, and we saw that for this patient, this is the averted amount of CVD deaths that will happen from intensive treatment, and same for stroke. And these are the additional harms that will be done by intensive treatment, syncope or acute renal failure. So for this patient, it's better to treat. But for this patient, it goes the other way around. So we could tell for each patient what is the best equilibrium. And we created a tool which all the data comes in from the electronic medical record. You hit calculate risk, and you get this clearly understandable impact of those treatment for that specific patient. And you can share that with the patient, and you can make a decision. This apparently seems to be very effective. And we were pretty happy that the New England also thought that this was an interesting option and a new way of doing those things. But it's not just showing them that. We also did a calculation. And the computer tells you, do or do not treat blood pressure intensively. But there's something that I haven't talked about in this. And there's a risk when you start using AI in healthcare. And I want to read this to you because many people make this mistake. This is by Kathy O'Neill, which is one of the forerunners in this field. And she said in one of her TED Talks, algorithms are not impartial judges. They are just opinions embedded in code. Isn't that beautiful? Because we say, no, the computer said no. This is not a higher intelligence telling us what to do. This is just somebody's opinion or a reflection of sometimes distorted reality embedded in code. We should be very cautious about using this in practice. And so one of the things we've done to try to tackle some of those things is to have the patient's opinion brought into this place by asking the patient how serious do they conceive each one of these outcomes, so they can say what they worry about more or less, and how they would want to optimize the treatment decision-making process. So if they're most worried about stroke because somebody in their family had this condition and they said, this is worse than death for me, and this is very serious, then they can say that and we can take this into heed. Or if they say, well, I don't know, you decide, then you have your basic definitions that you usually have in those algorithms. And the recommendation changes, but what the patient tells you to actually to put into the model. So this is one way in which we can embed the patient preferences and opinions into the algorithms. So eventually, this is the piece that was done by the New England Journal, and it shows, the hundreds of, groups that were trying to analyze the data, and then they were very nice to put this dancing thing on the top. But I think that what we probably don't do, data science that is markedly different than other groups out there. The advantage that we have is that our data science goes directly into practice. We are continuously talking to our physicians. We understand what they need. We create our tools and mechanisms based on what they are interested in putting into their daily routines. And I will tell you, they're not interested in more data. They have too much data. They want less data. They have little time, they have little patience, and they want to do more with the time that they have. If you add more chores to the daily routine and you're not trying to embed this in what they do, they will reject whatever it is you have to offer. So the point in which we are now as health systems everywhere around the world, and this country is no different, is really an inevitable condition. We want to provide universal health care, we want to provide high quality care, and we don't have enough resources to do it. Forget money for a second, we don't have enough health professionals to do this. If we continue in laissez-faire, if we continue the current system to move as it is, something will break. Either this will no longer be universal coverage, or there will be a huge gap between the care of the rich and able and those that are not, or that countries will financially go bankrupt because of their healthcare systems. And different countries deal with this in different ways. Some are slowly eroding the universality of their healthcare system, and some are providing lower quality of care, lower level of services. There are different ways to handle this. None of them is good. So I think the question that we all face is it true? Can actually digital health reduce cost and improve equity? Or is it like, Hal Wolf, which is the CEO of HIMSS, usually says he has an equation. OO plus NT equals COO. And he says the meaning of that is that old organizations plus new technology equals costly old organizations. So this is the other way to look at this. Can this be done? So what I want to suggest here is that there's two types of innovation in healthcare that we should bear in mind. One is the novel therapeutics, and the other one is the novel digital practices. And they are very different. It's mind-boggling the things you can do today with gene therapy, with stem cell therapy, with novel implants. This is wonderful. And there's also amazing things happening in the digital arena. Targeting high-risk patients, mobile-based telecare, the decision support based on AI, and digital therapies that are really important. But there's a marked difference between these two. And the difference is that those novel treatments are doing more with more. And so they will make our systems collapse quite faster. And the novel digital practice allows us to do more with much less. And this is real hope. If we can harness these new technologies, and we can bend the curve. We haven't seen it yet, but the potential is there. And there are some technologies out there that really, really have the potential to make this realized. So, healthcare systems, we hate change. We don't trust change. We've been disillusioned too many times. Novel therapeutics, novel technologies, again and again. But we're now in a position that we don't have the choice anymore. And we have to make this decision. And, you know, there's some new players out there with keen interest in the $6 trillion business that you roll in. And if we are not, as the traditional healthcare players, we're going to really embrace those new technologies, we will become marginalized within our own businesses, and justly so. So these are the options that every healthcare business has right now. And why? Well, you know why we are so conservative, right? It's because we are always focused on the risks of moving forward. And we've been disillusioned. And these are true risks, but what we are always neglecting is that there's an equation here. And there's a risk of the status quo. And we actually are failing on our patients every day that we're not transforming our system. If we put this in mind, we will be able to make better decision-making as decision makers, each one in their own field. So, it is not about the question who is better in deduction, if it's Holmes or Watson. And it's not about the question of who's better, is it Dr. House or DeepMind? It's about augmenting the physician's abilities to provide better care, more precise care, stripping him from his daily technical, mundane, repetitive chores, and giving him the time to do what he does best, what we used to do as a profession before all the routines came into place. And so many people are afraid that their profession is going to be eaten and that their jobs will be taken away by smart robots and algorithm. I don't think that's the case. I think the other thing will happen. It will bring medicine back to its greatness, take away the technical side and leave us with the humane part of providing our care to our patients. And so doctors will not be replaced by algorithms. But health systems that do not use AI in their daily practice, they will be replaced, and sooner than we all think. Thank you for your time. We can take questions now? Okay, good. Open for questions. Yes, please. I think the answer is all of the above. You cannot take a big problem, throw technology at it, and hope that it will be solved. It is a whole culture that needs to be changed if the new technology is going to transform. It is not the technical aspect that needs to be changed, it's the care processes that need to change. So doing the same thing we've done analogously and do it in digital manner is not innovation. And that's usually what people think. We'll take the current process, and whatever is done in one way, we'll now do it digitally. That's not innovation. And if you want to do innovation, you have to ask yourself, how does this new technology allows me to conduct the whole thing differently? Nothing that we've done in the past is sacred. The whole patient journey can change with the help of these new technologies without reducing the quality or putting too much harms into place. You have to ask yourself, how does the new technology bring value? First and foremost to the patient, and then also to the practicing practitioner. Because if you don't take care of those two things, it will break. And it will never move from beyond the pilot stage. Pilots always work great. There's a dedicated person who's really interested in making this work. He goes ahead and he pulls, and he makes it work. And then you try to scale and it breaks. And it breaks because you didn't ask yourself about what is the value to the patient and what is the value for the practicing physician and is it sustainable with their daily work. And only when you do, there's a chance of scaling. Yes?
I'm Ian Goodman, I'm Chair of Clinton CCG, and also co-chair of Northwest London Digital Strategy Group. Your health all healthcare sectors? So is it the same record in general practice as it is in the acute sector, or is it two separate ones that are linked somehow?
So what we've had, due to traditional reasons, we've had a single electronic medical record throughout our outpatient care, primary care, specialty care, every single physician's office, one single electronic medical record. And we had one single electronic medical record throughout our hospitals and hospital wards. And so those two have an interoperability system that was put on top that allows them to exchange data on very easily. So when you go today to an emergency room, the nurse can actually go online and see the data that was keyed in by the primary care physician 5 minutes earlier. When the patient is discharged and goes directly, drives from the hospital to their GP, the GP already has everything that was written in the hospital on their screens in real time. And that has been the case for over a decade now. So there's a full interoperability system between these two, and that has now it started at Clalit, and it now became national. So now, at Clalit, I can see any hospital, and any hospital can see all of the 4 sick funds. So that's now by now national system. Yes? So I usually find it's the case when we go to this question, it's usually brought by people when we have a discussion by those who want to stop the process. Because whenever you go deep into this question, there's 5 opinions in the room of the 3 options. And I will tell you, the answer is really simple. It's the patient who owns the data, period, point. That being said, it is being held by the healthcare organization for for the better service and better provision of care for them. And it is an assumption that they have put their trust in him, and the organization is provide their organization to use this data judiciously to improve his care. And so while it belongs to them, it is in safeguard within the organization to try to make good use of it to make the patients benefit at the end. So there's there's quite a large leeway for the organization, at least in the way we see it, in order to utilize it into good practices. But in the most basic term, it's pretty clear. It belongs to them. And for instance, if they move to another provider payer system, the data should migrate with them. More questions? Yes, over the back, yes. So there's a gradual process of integration that's taking place. The first reform that took place was when, about 3 years ago, we finally got mental health integrated into the sick fund system. So there's now one paying pocket and one provision that is done. That wasn't the case until then. So now that is well harmonized, and it's working as well as any other part of the healthcare system. The next reform or change that's about to happen is that of elderly care, social care, and all that trying to also be embedded in our sick fund system. Every year they're postponing it in a year, so we'll see. It took us time to get to the mental health as well. Right now, it's not as good as it should be. But at the most basic, the most basic fact known by every public health physician is, where would you invest your money to get the best health outcomes? Mother's education. If you had just $1 and you had to put it, don't put it in the healthcare system. Put it in an effective education for young mothers. That will probably give you the best bang for the buck if you're measuring health outcomes. But still, there's a lot of things that can be done within the healthcare system, also in these domains, social care, health education, etc., You know, it's a process. I think it will take quite a while before there's full integration of all of these soft things into one. I would mention one thing that we're doing, which is interesting. We're doing social impact bonds. So we're doing some of the first in the world social impact bond on diabetes. A group started by Sir Ronald Cohen that also started, you know, the social impact bonds on prisoner recidivism here in this country. We are now creating at Clalit bonds in which social investors buy so that an intervention can be done on pre-diabetic patients to prevent them from becoming diabetic, and the outcomes that come for it for different payers within the healthcare system and within the social system and within the national social security system, they all pay for success. So it's a unique mechanism that is now being employed. It's now in its third year of implementation. We have some great interim outcomes that we're waiting before we publish this. And it's worthwhile a bigger discussion.
I think one last question.
One last question. There was some here. Yes, please.
It touches on what you've just mentioned. You showed us some excellent graphs on very outcome-related analysis, but you must have patient-level costing. And have you run the two in parallel and go, well, actually, yes, we could get good outcomes, but for the cost, it's just not worth it?
So, you know, it depends on cost to whom and how do you look. Do you take a whole of society view? Do you take a whole of healthcare view? Or do you take the payer-provider view? And different views give you different answers on different interventions. Even from the very narrow perspective of the healthcare payer-provider system, I'll give you one example. We've created a whole prediction-based nurse-led intervention for multimorbid patients to prevent their deterioration. And we train those nurses and we provide really proactive care on those multiple chronic diseases for these patients. And what we've been able to show with a cluster randomized trial that by now has more than 1,500 patients in that, is that the cost of the intervention was offset by almost twofold by the savings for the healthcare system. Forget social savings, forget national level savings. It was offset by almost twofold, and we are now making this thing that started as a clinical, very large clinical trial. We're now making this a organization-wide implementation, adding a whole district on every several months, and so this is becoming from, again, the scalability, moving from pilot or small level assessment to the higher level. If you don't plan on your intervention to be scalable financially, then there's no point in going through the pilot. Stop here. Thank you so much.